Lovely. I'm going to start recording this again. So just to let you all know that the afternoon session is being recorded, and both the morning and afternoon sessions should hopefully be available on our STN YouTube channel for people to see, watch, and cascade amongst their teams at a later time. Just a few reminders before I start off with the afternoon session. If we could just keep our mics on mute when speakers are presenting. But then by all means, hands up and chat when we're in the Q&A sections. And we are going to be circulating the feedback form in the chat box as well. So we'll be able to provide certificates off the back of that. So just keep an eye out for that in the chat box to complete as the afternoon comes to a close. And I'll try my best to stay on time. Right, so move on to our next session, which is going to be myself talking about blood transfusion considerations for patients with sickle cell disease and thalassemia. Unfortunately, it's not Kelly who wasn't able to present today with a bit of short notice. So if I just share my slides with you all.
Can see that fine, Saba.
Perfect. Sorry, you can see them, yeah?
Yeah, that's correct, yeah.
Oh, lovely, perfect. And then let's try and do a slideshow. Please excuse any formatting differences between the slides. I've literally had to compile slides together from other presentations, so hopefully it all makes sense and we are going to be able to go through some good knowledge. So I haven't got the time. Should we give it a couple of minutes? I think I'll make a start. And if there's any questions, I'll check the chat box at the end of my talk and take it from there. So I'm coming at you today from a CNS hat at the moment, paediatric hemoglobinopathy CNS at King's College Hospital. So we've covered a lot of background and knowledge this morning, so I don't want to go over too much repetition. But just to start off our section this afternoon with indications for transfusion, which I know have been covered a little by John and Sama in a lot more detail. But the idea for transfusions in our sickle patients is to reduce the percentage of sickle hemoglobin in circulation, and this is mainly in the sickle and sickle beta thal population. In turn, this allows increase in oxygen carrying capacity in these patient groups and ultimately an increase in healthy circulating red cells. So these donated red cells that we transfuse won't sickle. They will help with carrying oxygen around the body to the affected areas and help turn around serious complications such as acute chest syndrome and manage severe complications like stroke. It also helps with priapism and other emergency presentations such as splenic or hepatic sequestration, which is the anemia that Dr. Babica talked about this morning. And we also actually use transfusions for major surgery. So prior to a patient with sickle cell thalassemia requiring major surgery, we would want to make sure that we've, if there's a lot of blood loss included in the procedure, to make sure that they've got some A in circulation, HbA in circulation, and that allows them to have a safer GA as well, because then those blood cells have got the oxygen carrying capacity that you'd need for a good general anaesthetic. So the idea is we're trying to suppress erythropoiesis of the patient's own bone marrow function. So just a little picture indication here. So what we're trying to achieve is a patient who's got sort of all HbS in circulation prior to transfusion if they're not on a regular program, and then afterwards we're hoping to get a mix where actually 70% of the circulation is HbA, so it's unaffected cells, and then if the patient was on a regular transfusion program, this is what we'd want to maintain at a 3 to 4 weekly interval. But if this was a one-off transfusion for a severe complication or for pre-surgery, this would then go back to the patient's own sickle blood being in circulation about 4 to 6 weeks later. So by the time the HbA is filtered out of the system, and their own bone marrow just replaces that with their own sickle blood. So how to transfuse? So this is very much a clinical decision, depending on the indication for transfusion as to what path you'd go down. So as John touched on, you could use top-up transfusions for more severe complications and automated exchanges. But if those aren't options, or it's out of hours, or the service isn't there, then we have got the manual exchange option. There's normally always an option around and available, depending on what needs to be treated. Ideally, you want to have some space in the hemoglobin to top up. So we wouldn't, if you've got a high hemoglobin, and by high for the sickle population, I mean if it's sitting around 100, we kind of consider that a high hemoglobin. You wouldn't want to go and put a top-up transfusion in and make them even higher than that if that's not what they're used to, unless they clinically need it, to avoid viscosity in the body, which in itself can cause further complications down the line. And another depending factor is having blood availability. So if you can imagine, if through childhood you're being exposed to blood transfusions and exchanges, and these units of blood are, you know, going to be coming your way, the more blood you receive, then the more the higher risk you have of developing antibodies, which I think I touch on in a little bit. But basically then, if you start to develop antibodies to donor blood, that reduces the pool of donor blood that you can then receive, because you don't want to then cause a reaction to blood you're receiving through a top up or an exchange. So there's other things to consider as well when you're going on to transfusions. So regular transfusion therapy, what we mean by this is transfusion therapy should be continued throughout childhood for secondary stroke prevention, and we do also use it for primary stroke prevention as well, but we are more readily using hydroxyurea to combat those that need if they've got abnormal TCDs, as opposed to putting patients straight onto a transfusion program. Unless their TCDs are sort of high abnormal, then we might think actually this needs a bit more of a severe intervention. So what happens is we're preventing recurrent stroke. So rate recurrence is as high as 70%, as John described from the STOP study previously. Monthly blood transfusions will reduce this rate of recurrence to about 13%. And the pre-transfusion levels should be high enough to suppress the bone marrow activity. So what we mean by this is that actually, so if you're giving a transfusion today and someone's coming back in 4 weeks' time for another top-up, we want to see that we've actually maintained a decent level hemoglobin for that patient, so that their own bone marrow doesn't have to produce sickle blood to correct the anemia, because we are trying to keep that sickle level down, and we're trying to maintain that S% at 30% for patients who are on secondary and primary stroke prevention. And so what we'd want is every 4 weeks or 3 weeks when they come in, their sickle percentage to be less than 30 or around that mark, and their hemoglobin to also be quite decent, so to be around or 12 to 13 ideally post transfusion. And so by the time they come back around in 4 weeks' time, we're just correcting a little bit of anemia, but then keeping the suppression of the bone marrow going as well. And as John said, it's effective in preventing further strokes. Revascularization surgery is also an option for those who aren't clinically, whose bone marrows are very active, and they're not tolerating top-up transfusions as well. And then we do monitor these patients with serial scanning, so they have TCD at least annually, if not more often, if there's concerns, and MRIs. We tend to do them sort of 1 to 2 yearly, depending on clinical diagnosis and what we're looking for. I'm just going to talk a little bit about red cell exchanges. So here at King's in Pediatrics is currently a CNS-led service. And it basically, this is the machine that we use here on the side. So it's the Spectra Optia machine, and it's an extracorporeal circuit. So you basically have a closed circuit in managing this patient. So it's all contained within the tubing and the cassette, and whatever you're removing is being replaced almost mil for mil throughout the procedure via the cell separator, which is just in the bottom of the machine. What happens with the exchanges is that you actually remove the patient's whole blood. The machine then separates it into red blood cells and plasma. The red blood cell then gets wasted into and will just not be put back into circulation, but the patient's own plasma is returned to them and joined with the donor blood. So just once again, so their own red cells will be wasted and will come out of circulation, but their own plasma will be separated and returned by the machine with the donor blood to the patient. So in my mind, that's like super clever. And it basically hopes to give a picture like at the bottom there. So where you've got lots of sickle cells in circulation there on the left-hand side, we're hoping to replace that with donor cells that will hopefully last in circulation up until their next exchange, when we just repeat the process all over again. It's quite an intense procedure, so it's quite invasive, I think, in comparison to a top-up transfusion, and it has its own set of limitations and things that come with it. So what I did was the best way I thought to portray this is to compare red cell exchanges to top-ups in terms of risk limitations of both. So red cell exchanges, you're exposed to more packed red cells unit because you're exchanging a larger volume of blood for these patients. So instead of using a 2 or 3 top-up transfusion, 2 or 3 units for top-up, you're using sort of 6 to 8 to 10 units per exchange to just exchange more body volume of the patient. Poor venous access is something that we come across the most in terms of a limitation. If you can't get a big enough gauge needle or catheter in to do the exchange, and the machine can't tolerate the pressures of having to pull and push the blood in and out. So if we can't do that, then it limits how we can provide treatment, whereas a top-up transfusion, you just need one cannula, one point of access to put the blood in. So we wouldn't tend to exchange patients who've got a hemoglobin of less than 70 because they haven't got enough in their circulating volume to allow priming of the machine. So we'll end up depleting them and making them feel unwell before we make them feel better. So it's better to go down the top-up route for that time, unless it's a recurring thing. But whereas a top-up transfusion, you have no lower limit. But you just have to be mindful that you're not giving too much blood at one time if they have got a low HB. If you are exchanging under, I think it's actually more like 38 kilos, then the machine requires extra prep. So you might have to use a human albumin or saline to prime the machine instead of using the patient's body weight, circulation volume, sorry. And if the body weight is under 10 kilos, I've not had to come across to do a patient this small yet, but I know some centres do younger patients, and I think you just need to have more special precaution for exchanges, but there's no weight restriction for top-up transfusions. So the benefits, so with red cell exchanges, you're more effective in reducing the S percentage in total circulating volume in one go. So you could get a patient down from, say, a 80% circulating volume to less than 30 with one sitting, whereas with top-up transfusions, that would take a couple of 2 weekly top-up transfusions to bring them down to that. So it could take, I don't know, maybe like 2 to 6 weeks to achieve that. Red cell exchange, as John touched on earlier, reduces iron burden for patients. So it's an iron neutralizing procedure in the sense that you're taking out red cells and putting in red cells at the same time. So you're not adding to the iron burden that blood provides. Whereas with a top-up transfusion, you're just putting in. So that's going to build up on the iron stores that the patient has and provide complications for them, which I'll touch on later. So with the red cell exchanges, as I said, it's only the red cells that are exchanged in a closed circuit, whereas if you're doing a top-up transfusion or a venesection will remove whole blood. So if you're sitting there with a cannula and pulling blood out manually with a syringe, you're pulling out whole blood, you're not able to separate that and return the plasma, etc., in the techie ways that a red cell exchange could. Red cell exchanges also provide longer frequency for procedures. So we have patients currently that come sort of 5 to 6 or 7 weekly for exchanges, whereas with top-up transfusions, it could vary from 2 to 4 weekly, depending on how active the bone marrow is and how well we're achieving a low S%. So just some side effects to a red cell exchange procedure. So blood transfusion reaction goes for both top-ups and for red cell exchanges. So we have the symptoms that you'd get with a blood transfusion reaction. So fever, rigor, chest pain, flushing. You can have shortness of breath, increase in temperature, and you would just treat this as a normal reaction. So you'd stop the blood transfusion and you'd want to pull back from the cannula. You'll need to keep your blood units and follow your local hospital policy for blood transfusion reactions in terms of returning and reporting, and your patient will definitely need a medical review to see what needs to be done to alleviate these symptoms, whether it's going down the route of anaphylaxis and EpiPen or just paracetamol and some steroids. So with red cell exchanges, the patients are also known to faint, so have vasovagal episodes. They can feel lightheaded, dizzy, nausea, hypertension. And they get quite clammy and a bit sweaty if they're going down that route as well. And this is expected due to the volume shift that we're doing in almost a short space of time, and at the speed at which we're doing it as well. So if there's signs and symptoms of this and we can detect them early, we do things to try and avoid it from happening. So you just sort of slow the rate of the machine and the exchange down, and you'd provide some fluids. So you'd give them a fluid bolus, or get them to drink more, get them to lie down, put their feet up if they're in the bed, and then let the episode pass and let them recover. And then you'd think about whether you'd restart the exchange at a lower rate or whether we need to sort of abandon the procedure for the day. So getting a medical review in there would be important. And the last main side effect that we get is tingling, citric toxicity. So for the machine, in order for the blood that's being removed to not clot in all the tubing of the exchange machine, it mixes with an agent called acid citrate dextrose solution. So in short, we call it ACDA, and it's basically an anticoagulant that joins the blood being removed from the patient, and it stops it from clotting all throughout the machine and all the tubing. But as a proxy, the patient will receive some of this through it being mixed in the plasma that then gets returned to them. And what ACDA does, it likes calcium, so it binds to the calcium in the blood flow of the patient, and it then removes that at a rapid pace because of the speed at which you're doing the procedure. And then in turn, you'll get symptoms of tingling, numbness in the fingers or around the lips, muscle spasms, chest pain, which are very similar symptoms to vasovagal. But if you can identify it as citrate toxicity, then there's IV calcium supplements that you can sort of provide for the patient. So in immediate circumstances, you'd put up IV calcium or consider oral calcium if it's not such an immediate reaction. Get a medical review, and then once the symptoms have subsided, you'd think about reducing your flow rate and reducing your infusion rates for the ACDA in order to prevent it from reoccurring for the rest of that procedure. And then you'd have to think about what to do for your patient for future procedures to try and avoid this from happening. And on the whole, it just means that we start calcium from the start of the procedure and not wait for them to get symptomatic. And this all gets explained to the patient as we go through and at the point of consent as well. Why am I doing the time? So iron overload is something that happens with top-up transfusions mainly, and it's considered chronic, so a condition you most often see in patients who receive multiple blood transfusions, and this is because each unit of blood contains about 250 milligrams of iron. Iron is something that we can't remove from red cells, so they will have to receive it, and then we have to manage that by giving collation to remove this. Excuse me, chronic iron overload can cause cardiac, liver and endocrine problems, and these are the organs that we're monitoring once the patient has started collation. So with every transfusion, we're looking at their ferritin levels, we're looking at their ACR, so the albumin-creatinine ratio in the urine. They have annual cardiac and liver scans to look at the actual iron deposit in the organs. If there's a high level of iron, then might go down the liver biopsy route just to make sure there's no sort of liver disease developing from this. And then particularly for thalassemic patients, you'd want to look at their bone density and bone age, and this is actually part of their annual review as well. So you just keep on top of their annual investigations related to collation therapy. So collation is the process that removes iron from the body. So what happens is after you've had probably about a year's worth of transfusions, we would then look to start collation. You wouldn't start it from the beginning. A lot of people have, why don't you just start on the day that I start and then it won't build up, because actually the medicine needs iron to latch onto to remove. So if it's not there to begin with, the medicine could become toxic in the body. So we actually have to let it build up ever so slightly before then we can start collation to remove it. And clinical symptoms of someone having excess iron overload would probably begin around 15 grams of iron, but this depends and also differs slightly between a thalassemia patient and a sickle cell patient. And if you haven't had this excess iron build up, then after about a year, you would consider putting them on collation if they've been on regular transfusions for a year, assuming that it's been built up, and then do the MRI scans. This has revolutionized the management of chronic iron overload. So before Xjade was available in the form that it is now, which is a film-coated tablet. It used to be like a chalky tablet you'd have to crush and mix with water. It was really sort of unpalatable, and children just didn't like taking it. So compliance, I've in my experience felt was very poor, and then it improved when Xjade came about, and it was a film-coated tablet that you just swallow like your normal paracetamol or ibuprofen. We still have deferoprone and desferal around, but it's not as widely used as Xjade. So these therapies are then moved on to like a second or third option if there, for some reason, a patient may not tolerate or comply with their Xjade tablets. So Xjade is the brand name, but I always trip up on the actual name, so do excuse me. It was 2016 when it came out as a film-coated tablet, and like I said, the molecules of it just lock around the iron, so it needs to bind to iron to carry it through, and you just basically remove that excess iron through your stool. And it does not turn your urine orange. So desferal, if you're using it over a long period of time, will discolor your urine, which is administered in a different way. It's actually a subcut infusion that you use either through, well, it can be subcut or it can be IV through a port or PICC line or Hickman. So obviously, if you had those three options in front of you, you'd want to pick the tablet that you take once a day, and hopefully compliance and adherence would be easier. You'd think it'd be easier, but it still remains a challenge. So it's taken orally once a day, and it comes in 3 different strengths. So you just find the nearest combination of milligrams you want to the body weight of the patient, and then monitor toxicity. So once you start on Xjade, you have to monitor renal and liver functions every week for 4 weeks to make sure there's no initial toxicity, and then you monitor every month with their transfusion. So side effects that you can have with Xjade include nausea, vomiting, diarrhea, abdominal pain, and these are side effects that we have seen through our clinic. It doesn't necessarily mean that you have to stop and start a different type of collation. You can always dose adjust and build it up slower to a more tolerable dosing. And sometimes we've paired nausea symptoms with antiemetics, so providing someone Danzadron or something to have alongside your Xjade is what we've also recommended, or giving it at a different time of day. So if you're getting particular abdominal pain that's not sort of so severe, having the tablets overnight has helped some of our patients to kind of sleep through those symptoms. So it's just kind of working with the family to figure out what the problems are, like we covered in psychology earlier today, and then figure out how it is best to tackle it to make it work for everybody where we can. And then more severe side effects are there, but I've not seen these massively since the film-coated tablets have come into play. I think they removed a lot of the intolerable ingredients of the Xjade when they remade it. So monitoring, like I said, we do monitor the use of collation every month with their transfusions. So monthly we'd be looking at their collation. Oh, so these are, sorry, I'm so sorry. These are patients that are on transfusion programs. So every month we would monitor their transfusion frequency. We monitor how much blood they're receiving and their collation dose growth. And then alongside that, we monitor their collation. So we look at their ferritin, liver function, virology every month. And then some of this we do annually. So the audiology and ophthalmology referrals are, like John said, related to the collation. So they happen annually. We also go down the neuropsychometric route. So depending on your reason for having a transfusion program would depend on whether you do get referred to psychology services for neuropsychometric testing. And then if you do qualify for that, we aim to do that sort of every 2 years. 2 years being, I think it's 2 to 3 years, because you don't want the patient to remember the test, in the sense that it should be fresh to assess them at that point in time, and they don't remember, you know, oh, we did it like this last month, so I remember the answers, that kind of a thing. We can do it sooner if there is a clinical decline or worry or concern, so it's not sort of a fixed time frame. And we also just monitor the general well-being. So when they've had like pneumovax done and things like that, because they don't come to our clinic as frequently as someone who might be on hydroxyurea might. So our monthly MDTs are very much a holistic view of these patients on a monthly basis to make sure we're staying on top of their cares. That was such a whistle-stop tour. I think I've got there for any questions. I'm going to stop sharing my screen though, so I can have a look at the chat box. Just bear with me 1 second. Oh, my screen's frozen. Just 1 moment.
So one of the questions is, where are you doing a manual red cell exchange because you are not able to separate out and return the patient's own plasma? Would they, in the case, also require transfusion of plasma in addition to the red blood cells?
No, so you wouldn't. That's a good question. So manual exchanges would happen on a PICU HDU setting for us, and I think in places that don't have the services set up, they get transferred into specialist hospitals. We don't replace the plasma, so you'd want to keep an eye on your platelet count and things going forward to make sure it's at a safe level to actually proceed with the manual exchange. But if you've got a patient that's presented to you with stroke, you that's the gold standard treatment that we can provide if you haven't got automated exchange, to exchange them and just get that S down. I don't think there's a massive burden on the plasma side of things in a manual exchange, but obviously if you've got access to the automated, then that would be, you know, that little bit more beneficial, but you wouldn't leave them without.
The next question is it standard practice for patients to have central line access if needing regular transfusions?
Yeah, so that's a good point. I didn't talk about the other access issues. So we basically, so the way I see it and the way I've always kind of advocated is to try and be as vein sparing as possible. If I'm very particular about not letting anyone just try and cannulate these patients when they're coming in for regular planned procedures. We're very fortunate here. We've got a day case unit that's fantastic at doing cannulas and venipuncture, and our patients really do trust them in that they know that it won't take 5 or 6 attempts to get a cannula. However, that's not the case for everyone. So if you're running into problems, for top-up transfusions, we offer single ports. So we can use that as a central device to do regular top-up transfusions. And for red cell exchanges, we offer double ports. And that allows us to have a big enough hub and access it with a big enough needle to be able to cope and keep up with the pressures that the machine requires. So we certainly do offer that. In pediatrics here at King's, we haven't gone down the route of femoral and necklines unless they're particularly unwell in PICU, and I'm not sure if that's similar in other centres across London, but I know the adult services do provide femoral lines, and they have like a set day where that patient will come in, go to interventional radiology, have the line put in, have the exchange, line removed, and then home. So they do it very much in a day procedure fashion.
That's all the questions.
Yeah. Oh, lovely. I'm trying to get my screen to work. Hold on. I think we're there. Have I stopped sharing?
Yeah.
Yes, I think I have. Okay, lovely. Was there anything else from anyone? Any hands? I'm just a little bit mindful that we haven't actually covered hydroxyurea throughout the day as a treatment option, and I wondered if anyone had any questions about hydroxyurea. I've got sort of 10 minutes until the transition talk with myself and Carol, so I'm happy to take some of that on.
can just Saba, just kind of talk, if nobody has a like specific question, just to kind of talk how exactly it works, because we have as a respiratory service, we will have patients on this, so I just want to know that kind of like how it's exactly working.
Was that hydroxyurea?
Yeah.
Yeah. Okay. So hydroxyurea is a medication that's taken once a day orally, and it's calculated on body weight. The way it works is that it acts directly onto the bone marrow of the patient, and what it does is it does a number of things. So one thing it does, it increases the mean cell volume of your red blood cell. What this does is it allows it to have a little bit more of a larger surface area and oxygen carrying capacity. So you kind of see that increasing in patient blood test monitoring, which shows a good response. Another thing you see is that then in turn their hemoglobin becomes slightly higher. So not all the patients have the same response, but if you have a patient who has a good response, you'll see that the hemoglobin baseline would start to increase over time. So you could have like a hemoglobin baseline of 80, and then after taking hydroxyurea for 6 to 9 months, they might sit more sort of 90 or up. And what hydroxyurea also does is it works on your bone marrow in helping it to produce more fetal hemoglobin. So once you're born, your fetal hemoglobin drops to like after 9 months, like 1%, and it just stays in the background. Hydroxyurea picks that up and tries to push it up again. So again, a good response varies between patients, but we can see something like 30 to 40% fetal hemoglobin in patients. And the benefit of this hemoglobin is that it doesn't sickle. So where you've got your HbS that will sickle and cause those complications that we've talked about, fetal won't. So that provides a level of protection to that patient, and then in turn causes less damage to the organs in the background from sickling. So the idea is that actually there's long-term benefits over your course of your life, in that you won't have the same damage in the background of your organs that you would then have problems with later on in life. So we do recommend for we'd certainly have the discussions in clinic from about 2 years of age with patients and their parents about starting hydroxyurea. But I know in the US it's licensed from 9 months onwards, and it's kind of offered to everyone routinely to have. However, side effects of hydroxyurea include dropping of your neutrophils, so you have to be careful with your dosing that you're not going too high and hardcore in, and you're monitoring the neutrophil count so that not to make your patients neutropenic or drop their platelets too far, because then you'd have to dose adjust to sort of rectify the white cell suppression versus the benefits that they're gaining from hydroxy.
Why is that? You know, as you're selling it to me, I would be like all over it, like my child was a sickle cell. So, but there is quite a lot of reluctance with parents, and I know you told me the side effects, but they must know about something more to it, because there is such a like absolutely not, or they are fine. So there is nothing in the middle, and I was wondering what they're reading about, what are they mainly worrying about?
That's it. So the main thing that a couple of main things that we come across with hydroxy is that so historically it used to be used in treatment for leukemia. So it was related the drug itself was related to cancer, and then there was maybe really small evidence that actually it could lead to leukemia or ALL, but actually we're not giving treatment doses that high that would put a patient at that risk. We're giving very sort of controlled amounts in relation to body weight that we don't actually, I don't think we push our kids into that category. And also there's some question about whether it affects fertility, especially in men. So teenage boys, if they're starting on hydroxyurea, we would still recommend that they sort of sperm bank before starting. But if they're sort of family planning, the recommendations I think are still that you stop hydroxyurea for 3 months when you're thinking of planning your family, and then restart once you know that is kind of over. So there was reservations about that as well. So those kind of things are still out there in the community, and we haven't got enough evidence, as far as I'm aware, for the fertility issues yet, but we do have options for patients to try and help them.
There's a question in the box.
Yeah.
So it says, do they have to take it for a certain time before any benefit is seen? And if so, what is used in the interim?
So I think our clinicians are quite open through our clinics in that if you're going to give hydroxyurea a try, you want to give it a good 9 months to a year to see the effects of it fully come to light, because it's a cumulative medication. It builds up in your system. The more you take it, the more it builds up to the maximum amount where you see the benefit. So it's not like a quick fix like paracetamol or ibuprofen. You know, you have pain, you take it, you're better in half an hour. Hydroxyurea very much builds up within the blood system, and the action on the bone marrow is something that happens over time. So if you want to see a reduction in painful episodes or complications at home, definitely give it a good try for a year. And if after a year, you know, we've managed to get you on a maximum tolerated dose, you're still, you know, not sure, or it's not improved, or things are still happening, then that's a discussion for then. But I think you'd need to commit to solidly trying for at least 9 months to a year to make sure that you've really given it a chance to work.
And what would you use in the interim, or do you use anything in the interim?
Not really. I think you kind of want to just make sure that you're working closely with your clinician and attending your appointments to dose escalate very quickly. So if you're starting at a lower end, I know there's recommendations now to start hydroxyurea at a slightly higher dose. So where we would start at sort of 15 to 20 milligrams per kilo, there's more evidence to start at 25 milligrams per kilo, just so that you're not delaying the process of building up the medication in your blood system, so that you're getting the effects of it a lot quicker. So I think it's just having that little bit of patience and then monitoring yourself how you feel when you're taking it, and just getting to a maximum tolerated dose almost as quickly as you can.
That's it on the chat box.
Lovely. Okay. A little bit of bonus hydroxy there for everyone. Yeah. So I think we'll see if Carol's on the call, and then you're going to hear more from me about transition. Let me open up the slides. Is Carol on the call yet, or should I just give it a couple more minutes?
Hi, I'm here.
Oh,
I'm here.
hello. Hi.
Hello. I'm here.
Perfect timing. I was just gonna get started on a couple of the transition slides I've got first. Is that all right?
Yes, perfect.
Yeah, perfect. Let me just share my screen again. Bear with me, please. Okay, can we see my slides?
Yeah.
Perfect. Lovely. Okay, so our next talk is going to be hosted by myself and Carol. So I'm coming again with my nurse specialist hat on, and Carol Rose is our lead adult transition CNS here at King's as well. So I'll be covering some of the background transition stuff, and then Carol will take forward how the service is kind of run here through King's as well. Right, so let's just have a look at the time. Very good. Okay, so what is transition? So transition, in healthcare, we use the word transition to describe the process of preparing and planning a young adult or a child through the teenage years to the adult services. Now, I've had some comments about how the word transition itself now, in terms of gender, is starting to mean different things, but we're very much using it in the context of moving from pediatric to adult services here. So just to make that clear. So transition is a gradual process that gives young people and everyone involved time to get the young person ready, not just the young person, but the parent and the family as well, to move to adult services and discuss what healthcare needs they will require as an adult. Transition services aim to bridge the gap between children and adult services, which Carol will talk about in more detail. The transfer of adolescents from the children's services to adult services is a crucial time for health of young people who may potentially fall into a poorly managed care gap. So it's very difficult, and I've got so it's basically working alongside the family as well in terms of the life events that are happening for these young people, moving over and making sure that actually their health care and needs are tied in with what's going on in life as well, to make sure that they're not sort of falling through this care gap that you get typically around the teenage and young adult years. So transition is the purposeful, planned movement of adolescent and young adults with long-term physical and mental conditions from child-centered to adult-orientated healthcare systems. So as well as growing up and having to take on the responsibility, they're very much going into somewhere where mum and dad talk and mum and dad sort of lead and make decisions about care, to a place where actually now they're having to sort of think and make those decisions and do that for themselves, which in itself is, you know, quite challenging. So it's quite an important time. Transition can also be defined as a multifaceted active process that attends to the medical, psychosocial and educational needs of adolescents whilst they move across the services. And it's a process, it's definitely a process. We try very hard not to make it a one-off event, which can't be avoided in all scenarios, but we very much do try, which starts within child services. So you want to capture these children around the ages of sort of 12, 13, to start having those conversations about where they're going to end up by the time they're sort of 18, 19, 20. So it gives them that time to process the transfer and their health needs that's going to happen, but hopefully before they get discharged from child health services. And the transfer does not represent the end of transition. So it's very much like, oh my gosh, I'm 18 now, I have to go to adults and this is it. We try to make it very much a process, in that the young person would still be considered in a transition process, I'd like to say, up until the age of, well, early 20s, to whenever they feel that they're ready to, you know, take the leap and sort of carry on themselves. So I've just got a little example here of a flowchart of an ideal transition pathway. Like I said, it unfortunately doesn't always happen like this, but this is what we strive to achieve. We identify the young person that needs transitioning and empower them, and support the parents with this as well, and start transition planning. I found through experience that actually the work comes first with the parents, that we're going to start transitioning your child into adult services and talking about these things for them to have a time to prepare, and then you then start addressing the child. So it's really working with the family as a whole and in their expectations as well. Then we review these patients as a multidisciplinary team and refer on to lead adult services, and we try to provide joint clinics where both the children's services and adult services are present as a means of introduction and ongoing care. And with sickle cell patients, what makes it tricky is planning their urgent care. So we are a little bit bound by the age restrictions in places like ED, and if you've got ambulatory units that see them in hours to avoid ED, that provides a little bit of a barrier, but it's about working with these different departments into making sure that care is still sort of patient-centered, and then helping the young person to feel confident into adult services and into all the joint clinics that they might come across going forward. Now I've got this slide here. I hope you guys can see the animation. It's pretty cool. So it just basically is just reiterating what I've said in terms of children's to adult services. In our case, we're very fortunate that we've got Carol, and she'd be the named worker to help coordinate and transition care and support for these patients, and start planning this and identifying the needs that they may have to take forward, and making sure that care plans and personal folders are developed in a way that addresses all their needs in one place, just to make it a bit more easier to coordinate moving themselves through the transition process. So Ready, Steady, Go is a program that provides a pathway that I think we do try to mirror here at King's anyway. And this is what I was saying before about looking at where the young person is in their life in terms of what events are happening. You know, you're starting secondary school, then you've got your GCSEs, your A-levels, university, you're in adults. So you want to kind of try and move responsibility of taking ownership of your care in conjunction with that. So for example, by the time you hit 16, you'd be, you know, the expectation is there to make your own GP appointments, and, you know, you don't necessarily need a parent with you. You can look at requesting prescriptions, just doing little things to build up your independence. It's not just a stop and it's all you now, but it's more helpful to try and tailor this around the time of life that the young person is in, to not overwhelm them or underwhelm them. You know, it's just working with them to be able to move forward. And these are the slides that I have before we now switch over to Carol.
Yeah, hi everyone.
Perfect.
Thank you, Saba. Lovely presentation. Let me just see if I can share. Just bear with me. Okay.
Yeah, we can see the slides.
You can see the slide. Good,
Perfect.
good. Okay. Right, so I'm talking about the vision of implementing and improving the transition care here at King's. So I will actually miss the transition part because Saba done a fantastic talk around there. So I'm just going to go straight into objective of what I'm going to talk about or cover today. So the key issues: bridging the gap between the paediatric care to the adult service, understanding the emotional impact on the adolescents and young adults, improving the transition service. And then what are the key issues? So the key issues is bridging the gap between the paediatric and the adult service. Again, smooth transition care, empowering the young person, patient to receive adequate information about their condition, the young adult to gain independency, their autonomy and their involvement in decision making, and again, improving follow-up, improving DNA, because as you're aware, patients tend to DNA quite a lot. Again, looking at the flexibility in terms of appointment, maybe looking around weekend appointments, doing something like twilight clinics, which would be in the evening, and obviously the video attend anywhere. That would be good because obviously young patients would be able to attend that if it's attend anywhere. So therefore, the positive is they don't have to attend clinics. Again, looking at peer support, mentor and buddying up with someone. Again, looking at adolescents and young adult workshops and education workshops and individualized care plans. And again, putting together a focus group that obviously gives young people a chance to raise their concern. Transition barrier, what are the barriers? So obviously the barriers are, which all are aware, is that the young people, the adolescents, they're used to their pediatric team. They evidently have a trust with that team because they've been there from a child right through to they become the young adult. And unfortunately, they become quite scared, frightened to come into a service that is unfamiliarized to them, and also become quite daunting, especially if they've heard negativity. And this, unfortunately, can cause failure for young people or young adults to attend their appointments. Again, as we already know, it can cause severe anxiety. Again, young people, young adolescents, they tend to lose trust actually with the staff, and that would be because they may feel that the staff, whether it's the nursing staff, the doctor staff, that they may feel that they're not being listened to in terms of their needs, and may feel that some of the staff may not have accurate knowledge about their condition. Therefore, sadly, this will avoid young people from going into the hospital. And again, the potential is to compromise their health. Again, we talk about, sadly, the negative stereotype in terms of young people coming into the hospital environment, and therefore their fear over the adult side is facing discrimination. Again, there is a bit of lack of reliable information that's available for patients and parents. And again, there are some poorly managed transition services. So the misunderstood disease. As we are aware, sickle cell is invisible nature, therefore it's a hidden disease that cannot be seen. So therefore there's a lack of sensitivity to the psychosocial needs of these group of patients. The judgment, sadly, from healthcare professionals and patient complaining of pain, in which sadly healthcare professionals cannot verify or see. Therefore, unfortunately, that's how they feel in terms of being stigmatized through this. So again, we talk about patient experience when they go to ED. And we've had some patients, obviously, that may have gone through transition, but when they come to ED, they may have their care plan, but unfortunately, for some reason, that don't get identified when they're there at the ED department. So again, it's talking about delays in receiving analgesia, inappropriate choice of analgesia medication, inadequate review of pain, and again, feeling and being perceived of behavior drug seeking. And this again, sadly, can lead to more severe complication, patient frustration, and a breakdown with health professionals. The emotional impact is quite heavy, obviously, as a whole. So the young patient can have fear of dying, especially if they've been an inpatient, and especially, or they felt that their care has not been as it should be. They feel also isolated in terms of who can they talk to. Again, in pain, they may feel angry against going through that pain, being identified of a person that may be drug seeking, and that's sadly going to make them feel angry, and not getting sufficient pain relief. Again, the young person can feel low self-esteem, going to school, individuals not understanding what sickle cell is. Again, depression and anxiety. Well, what we do, again, we provide individualized care plan. And again, as I stated, sometimes, unfortunately, the care plan, when the patient goes into ED, sometimes they can't find the care plan. So again, that's a bit of a challenge. And sometimes patient may not have care plans. So these are quite challenging factors. However, when they do have the care plan, it goes actually quite well, because the patient will come in, and the hope is that they get the medication, as you can see, within 30 minutes on arrival. So again, that's positive. Again, it's also about looking at patient focus group. Why is that important? That's important because it's about understanding the young person's feeling. How do they feel? What are they going through? What are they experiencing? Again, is about what does excellent care look like? And again, that's about working with our patient to get a full understanding. How can we improve that for the patient, advocating for them? Right, so now looking at the transition vision, bridging the gap. So bridging the gap obviously is about preparing. And by preparing, is about preparing a young person to go through pediatric to the adult side. So by doing that, is about doing assessment. I think Sabah talked about Ready, Steady, Go form. And again, it's about looking at the assessment for the young person, whether they're ready, and if they're not ready, how can we support them, and how we can make that transition quite smoothly for them. Now, what I've also identified, some point in the clinic, sometimes what I found is that easily can miss the patients, because obviously where I'm at the moment, when patient come, there's not many clinic space, so there's another challenge there. So because there's a challenge there, I guess it's about looking at, okay, what alternative can be done? So again, it's trying to set up a nurse-led virtual clinic to capture the patient, to go through the form, the assessment, and again, it's about that private and confidential instead of talking inside the waiting area. And again, it's about meeting the community nurse, sitting down, going through the list for the following week, sending out reminders for the patient, because as you're aware, patients do DNA, and sometimes, unfortunately, patients forget, parents forget. So it's also about trying to remind them. And again, that can be quite consuming. And again, the challenges is sometimes you don't have the correct telephone number for the patient. Again, it's about identifying when the patient is ready to go through the adult service, as I said, and it's also about looking at the complexity of the patient and in regards to treatments. And again, that evidently needs to follow up closely. So again, which also is important is to, as the transition lead, is to also put together a ward round with the pediatric team or the pediatric CNS, or just doing a ward round independently, just to follow up the patient, just to look about their well-being and to give them support, and also just to, that they can identify who I am, and that hopefully will help with a smooth transition over to the adult side. And again, it's about the parents, as Saba said, it's about getting the parents and putting them also at the forefront and getting them to be familiarized with us as the name person, and with the side of coming over to the adult side. What is their expectation? Again, is a transition meeting with the transition CNS. Why that's really important, because the hope with that is picking up anything that has been missed during the pediatric clinic and just before they get into the transition clinic. And again, it's talking about conditions, it's talking about their treatment, any complication, any social issues, housing issues, anything that's outstanding, that obviously when we do the combined together, then obviously we'll be able to bring that back to the transition clinic. And hopefully we could do this on MS Teams or the video link. What's the time? Okay, I'm still on track. So anyway, so the other video is about the individual patient pain alert card. So obviously, as I talked about prior before, that sometimes when patient come to ED, for some reason the pain protocol is not there. So the pain alert card is something that is like a credit card, and therefore it's about having the information on there so that that patient can carry with them around them wherever they go. And what's good about that, even if they ended up in South London, East London, North London, the hope is that with that card they will have the information, and also the information of to contact us, the hematology team. Again, it's about building a relationship with the patient using technology. Again, young people are very much into technology as well. So I think that's something that would be coming to the forefront. Again, patient tour and introduction, obviously to get the young people to feel more at ease, and to help them not to feel so scared and afraid to come over to the adult side. Therefore, that's why we do a tour, in order to introduce them to the staff and introduce them to them where they would go once they do come over, whether it's ED, whether it's in clinic, or whether it's in a day unit. The other thing that I thought was was something that would be great to do, was to have a website for the adolescent and the young adults, something that they could build along with us, to see what is it, again, it's going back to the focus group. What is it they would like in terms of improving the service? I'm already having a workshop, my first one, so wish me luck, on the 28th of October. And with that, I incorporated some short talks. So just to talking about my role, the adult seniors role, just to talk about and bringing what is needed when they do come over to the adult service. Again, I think might be out there, I don't know, but I think it would be good to create and design a booklet. Again, it's just about equipping a young person with information. It's about empowering them to be independent. Again, I thought the good idea was maybe looking at them creating a folder, something that they feel proud of, something that's about what their health condition is, their social need, anything they've achieved at school, at college, etc. Something that they can bring that they actually feel proud of. Again, we talked about the tour video. We talked about the tour, but it might be good also to do a tour video of the adult service in case you can't do face-to-face. And again, it's about reducing their fears. Again, it's about setting up nurse-led clinics, virtual clinics. So one of the virtual clinics that I'm setting up, it'd be from the age of 40 to 24. And again, I talked about focus group. Again, it's about building and bridging the gap and trying to give as much of support that we can give to the young person in terms that they can have more access, give them more empowerment, give them better care. So again, it's talking about a drop-in session, maybe on a monthly basis, and that will give the patient or the young person the opportunity, if they need to call in, and if they've got any concern or any worries, they can talk about. Again, it's all pain management, well-being, monitoring their medication, if they've got any advice that they need. And again, it's about reducing fears, anxiety, and sense of isolation. Okay, so we go on to putting together education workshops, which are, I've done them in the past. They're very excellent. And again, it gives the patient a bit more understanding about their condition. It will gain confidence, reduce and manage symptoms, side effects, reduce stress, anxiety, and help manage pain. And what's great is that they can meet other people, other young person that's also coping with a similar condition, and also maybe introducing other conditions that they can see that is not only them that also go through all the condition that they do go through. And not to forget the parents. I think it's good about doing coffee morning session to get also their fears. How would they like our service to be improved? Again, here at King's, we do adolescents clinic first Monday of every month, which includes the team. And within that clinic, we give a goodie bag. So in that goodie bag, well, when they are ready to move over, we actually give them a goodie bag that will have their up-to-date care plans, their clinic letter, a thermometer, dossier box, the NHR cards available, and anything actually that we feel that's appropriate to put in the bag, and informations. Therefore, then after that, obviously, they come into the adult clinic, which again, that's why I'll be seeing them when I set up my nurse-led virtual clinics. I think it's important to have quality improvement projects. We want to work with young people. We want to make changes and improve that. And by doing that, we have to work together as a team. A lot of the issues, as you're all aware, is the ED, accident and emergency department, and obviously on the ward. So again, if we put like a steering group together, that's a way to improve. And again, it's just regular teaching. What's also, again, I'm going to emphasize focus group, patient survey is very important, because with that, this is how we get the idea of making improvement in our service. Summary, again, you know, having the lead nurse, the lead person to have a better service, to create a safe environment, and to get the patient voice to be heard. Working collaborative cross team working, listening to and engage with adolescent, young adult and the family, getting through it together. So it's about us working as a team with our patient, and again, ongoing education for adolescent, young adults to raise sickle cell awareness and promote emotional well-being. And also, again, I go back to it, is about we need tools to measure transition outcomes, again, patient surveys. And again, thank you very much.
Thanks, Carol. That was brilliant. Thanks very much. We've got just a comment here from Mira, which I think is very good one, which I'm going to share. So I think the level of pain, Mira has said that she thinks the level of pain for these patients is really misunderstood, which is an ongoing issue that we have been sort of trying to tackle and deal with. As a young person, shows higher level of pain, and clinicians in A&E are more worried about the side effects of Oromorph. So it's kind of a lot of myth busting is what we have to do when it comes to providing these teaching sessions and things across the floor. Tell us about your experience, Mira, in A&E. Yeah, go for it.
Saturday night. This Saturday night.
Exciting.
So yeah, it's quite interesting. Yeah, you know, when you were saying about the card or like a care plan, whatever, I think it's great. But I think probably like over the weekend, you know, like when they're in so much pain, they might have, I don't know if it will be useful to kind of like have it all the time, somewhere where they can grab it immediately, because I have a feeling is they're in so much pain and they need to go to A&E. That's the last thing is probably they're looking for. They just want to go to A&E. I think he was actually transferred by ambulance anyway. But when they came, I mean, luckily there was a clinician who kind of understood. But you know, for example, nurses, he came, he had a codeine at home already, and obviously whatever painkillers wasn't working at home. That's why he's coming to A&E. Next step is something else. But they kind of question that. And I'm thinking, you know, like, I don't know, is it a level of education in A&E by the nurses as well? But luckily there is a clinician who says, actually, no, this wasn't working. That's why he's in A&E. We need to give the Oromorph. But it starts, as you were saying, start with the A&E triage.
It starts with the A&E, and that's why this is thank you. You what you said is absolutely correct. And again, we're going to go right back to education. The thing about ED as well, there's always a high turnover as well. So that's also can impact, and that also could be challenging. So I guess coming back to that, we have to educate ED much more often. We need to have more link nurses, so link nurses in that area. And also it's about educating our patient. It's about catching them before they reach a point where they do need to come to ED. And how do we do that? We do that by setting up virtual clinics, by teaching the young people, and not just young people, the adults as well. It's about teaching them to understand what is pain, how do pain work, how can I prevent it, and it's about looking at, like we work with 1 out of 10, it's about teaching that to the patient. 10 is worst pain, and when I used to teach my patients about pain score, actually they didn't understand. Their ability of understanding was, okay, Carol, I take my pain relief when I reach about 7.
But you know, we have to, yeah. It's quite interesting, because what I found, because I mean, I've been a nurse for a while, and I looked after the sickle cell patients with leukemia. So it's with the sickle cell and pain, it's completely different ballgame, isn't it? Some children, I mean, some even young adult, you know, teenagers, when their pain is horrendous, they don't talk. But the heart rate can be high, blood pressure is high, everything is horrendous. Clinically, but they don't show it as much, right? But the pain is horrendous, they're on PCA. Then you have another one, very similar, who is screaming their head off. The whole department knows that they're in pain. Now that is confusing to nurses. So that's why they will say, well, the pain is not as bad for sickle cell if this patient is okay, and then this one isn't. You know, because the pain can be, because it can be such a, it can be such a horrendous pain, and it's horrendous pain for everyone, but they are not reacting the same. So that's confusing.
Could I comment on that? I just think that the thing about that, this is a question that when I'm in my teaching nurses, this is what I say to nurses: tell me what your worst pain is. And a lot of people will say teeth pain. And when you look at tooth pain, or you give birth, or you've got gastric pain, or you've got a migraine, think about migraine, tooth pain. We can't see it. And sometimes we can have a massive root pain, but actually nobody knows that we're in pain, because it's not something that we're using our body language. Do you understand? So I always say that's similar to the sickle patients, where they can come in with pain, but the problem is they'd be so used to that pain that they hold on to their pain. Yeah. It's the same principle if you've got a tooth pain, if you've got a migraine, and if you're someone that has migraine, and I've experienced migraine, no one really knows until it gets to a point where the room's got to be really dark, and I got to aura. But the thing is, my colleague's not going to know that actually I'm about 8 out of 10 in pain. Or say simple if you have a back pain. So I think, again, the thing is about teaching staff that don't think about the sickle, think about what pain is to you. And if you can measure the pain, if you're somebody that understands pain, then you will understand that there are some patients that don't manifest the crying and a lot of pain. Actually, some of these patients are very quiet.
Yeah.
And that's how they get judged, because they're quiet, or they've gone out, they've got a cigarette, they're on the phone, but it does not mean that they do not have pain. And that's the education that we have to get over to our colleagues.
I think in terms, if a sickle cell patient tells you they are 10 out of 10 and they might not be screaming, you have to believe they are 10 out of 10.
You have to believe,
and then you have to treat them the same as the person who's 10 out of 10 but crying on the floor.
Just to also go off what Mira was saying, the HCC team are actually producing 3 short clips, and one of them is surrounding pain management, and you do actually hear from patients directly to tell you how they deal with their pain themselves. So this is going to be an educational tool which has come out of the APPG response. We are trying to finalize everything and actually have it out in hand with the anniversary of the APPG report, which is in November. So hopefully by the end of November, we should have these, I think there's 3 of it. Yeah, there's 3 short clips, about 5 minutes long. They all go around different topics. One of them is definitely pain management. And I can specifically remember the clips where the patient, there's 2 different patients. One will tell you, for me to release the pain, I have to scream, where another patient will tell you, I would rather just hold on to the areas where it's painful, and that's it, and they'll keep quietly in the corner. So yeah, just to reflect on that, we have got educational clips coming out, which will be primarily for the A&E team, but they will be available for every staff and around all our trusts. So hopefully once they are available, we will promote it through the intranet, the STSTN website, through all our platforms. So hopefully you guys should be able to also view it as well, and then hopefully that should allow the nursing team to have a better understanding on how to manage the pain a bit more effectively.
And that sounds really excellent. And before I leave, may I just leave something with everybody? If a cancer patient was in a lot of pain, or a cancer patient not in pain, it wouldn't be questioned. A patient can come with a heart attack and actually could go through all of that and don't get ignored, or no one's saying to them, well, actually, are you in pain? And this is what we need to be aware of. Other conditions that actually they do get support, they do get recognized that they are in pain. So just something for all of us to think about. Thank you very much.
Just a quick question in the chat.
I was going to say, yeah, go on. So I've just got a question in the chat. I've got Caroline, and then I just wanted to also say to Mira, the pathway for ED also differs between peds and adults. So in pediatrics here, we use a set guideline for everybody who comes through and a set flowchart for pain management. And it's when they get to 16 and older that they get the individualized care plans, because adult ED here works very differently to peds, and we've tried to cater for both. So an under 16-year-old may not have a care plan with them. So you just use the generic pain management path.
And where would it be? Is it on Quicken?
Absolutely, yep. And I think they've got posters stuck around in majors as well. It was one of the bits that came out of our PREMS report. So hopefully those bits are around, and I'll certainly be double checking on that now. I've just got a question here, Carol, for you from Helen. Have you got any tips on how to engage the young people in the transition process, i.e. actually getting them to come to workshops and engaging with the service?
I think it's about, I think firstly should do a focus group actually and find out, do they want a workshop? Do they want an education day? And if they do, what would they like to be included? I think what's important is to evolve the young people. And actually, I go a bit further, maybe get them to actually put that together with the support of yourselves.
That's brilliant, thank you. And then Caroline, I know you had a question if you want to ask it.
It wasn't really
Go for it.
as such. It was more to talk around the attitude that the nursing and medical profession have towards people with sickle cell. Like Carol said, if a patient presents with, you know, whatever their condition is, whatever they say is trusted, accepted, and believed, and they're treated. It should not be different for people with sickle cell. And it is. I have been in nursing and nursing children for a long time. It has not changed. The conversation's still the same. The attitude's still the same. We need to work harder at listening to the people with sickle cell. It's not about just looking at protocols. It's not about just looking at care plans. You know, it's about listening to that person presenting to you with pain and trusting that their pain is what it says it is, as bad as it says they say it is. Yeah, and ask them, what do you do? What do you need when your pain score is 10 out of 10? What do you do when your pain is 5 out of 10? You know, I work with a lot of families and young people in the community, and I try from the age of like 3, 4 to get them to understand the pain assessment processes and how to use them in the clinical setting. Because it seems like just saying I have pain and my score is 10 is not enough. You know, they need to fully understand what's a pain score of 10 for them is. It's not about that nurse's experience of pain. We don't have to have gone through their pain because we can't. We do not have sickle cell. They do. So we need to start listening to them.
Thank you, Caroline. Thank you, and I absolutely agree with you. And I can go further a little bit more. It's about health equality, sadly, and it's about the lack of understanding of Black patients, and it's about the stigma. And until we can recognise that actually and make changes, and only then, sadly, everyone will listen. So it's about in health equality, sadly.
We've just got one more question. So it's saying, once transition has taken place, can a parent stay with them to start within the adult wards?
I guess I'm still quite new here, so from what I've gathered, no. But to be fair, I've had 2 patients that were actually quite poorly or quite unwell, and they did allow the parents to actually stay. So I think it's about depending on the circumstances. But I know that it's not equally the same as pediatric, because I am aware with pediatric patient can stay, but I think it's very difficult for patients' parents to stay on the adult ward. But I have seen it happen twice, and again, it was because the patient was very seriously unwell. I'm not sure if that answers your question.
I think that's it from the chat.
Yeah, lovely. Thank you very much. Oh,
Thank
Carolyn.
you. Oh, that's all.
I was just gonna say, I work closely with the team at Queen Elizabeth in Greenwich, and I know that the transition nurse had done some work with a couple of the adult wards that look after the young adults, and they do have a little bit more. They did agree to a little bit more flexibility with regards to patient and parents staying with the patients.
Oh, that's good. Maybe it'd be great if you could send me the email of the nurse in question that helps support that, and maybe I can kind of bring that to the team here. That would be great.
Okay. I'll have a chat to. She's Bethan Williams. I'll have a chat.
Okay, brilliant.
I'm sure she'll be willing to support that.
Yeah, of course, of course.
Okay.
Perfect. Thank you very much.
Thanks, Caroline. Thank you. Thanks, everyone, for all your input in this session. It's been really great. And I think we're going to move on to the next session. So I think Kim is on the call. Kim Newell is oh hi, hello. So Kim Newell is the lead hemoglobinopathies children and adult nurse at Barts Health Trust, a Royal London hospital, who's kindly agreed to come and speak to the group today about thalassemia management in childhood. So again, if we could just keep mics on mute whilst we are in the talk, and then we'll come to the chat and any hands in the Q&A just after. So I think, Carol, if you could just stop sharing your screen so that Kim could share her presentation.
Yeah, then I'll share my...
Carol, are you there? Oh, lovely. Thank you.
Yeah. So
yeah, thanks. No, that's okay. Thank you.
Oh.
Perfect. We can see your slides, Kim.
You can see my slides. Okay.
Yes, absolutely. Thanks very much.
Good afternoon, everybody. I know you've had quite a full day of talks, and I'm in the last session, and I wasn't able to join for the whole day, and I've joined sort of for this afternoon. So I'm sorry if I will overlap on anything. But today, as Saba said, I'm just going to talk about a little bit about thalassemia. I've got about 20-25 minutes, so that's a short time to talk about thalassemia, but in children. But anyway, we'll see what we can get through in this time. So what is thalassemia? So it's a hereditary blood disorder which affects the production of hemoglobin. So this comes about by the reduced or absent beta globin chain synthesis, which then impacts on reduced hemoglobin in the red blood cell, and then reduced hemoglobin red blood cell production, which then leads to anemia. So this is sort of the process that happens. And so what we say that basically, if you want in a simple word, that thalassemia, the body does not produce enough hemoglobin. And quite often before, when I've had like students and we talk, what's the difference between thalassemia and sickle cell? I would say that sickle cell is to do with the quality of the red blood cells, where thalassemia is to do with the quantity. So that's just to answer something in one quick sentence, is to do with the quantity. So inheritance, I'm sure you've gone through this sometime during the day, so I'm not going to really linger on this slide, but it's basically the same inheritance pattern as you have with sickle cell. It's a recessive gene where both parents have to be carriers of the abnormal gene. So the thalassemia syndromes, you've got the beta thalassemia and you've got the alpha thalassemia. And then these are sort of just a list of the really the most common ones, but there might be one or two other ones, phenotypes that you very rare and maybe quite insignificant. So you've got the homozygous beta thalassemia, and you've got the beta E, HBE and beta thalassemia, the HB Lepore and beta thalassemia, and sickle beta thalassemia, and that's on the beta chains. And on the alpha chains, you've got the homozygous alpha thalassemia, which is not really, if you've got not conducive really to life, you've got the Barts hydroxyurea, and you've got the hemoglobin H. Now here within the Royal London, around Whitechapel, the ones that we see the most is the hemoglobin E a lot, because that is more prevalent in the Bangladeshi population. So we see a lot of the hemoglobin E, and that's why our population of thalassemia at the Royal London is really high. We have 40, 50 children with thalassemia, and over 20 of them are on transfusions. So we've got quite a large population. I've also got the beta thalassemia as well, and we get that more with the Pakistani populations. So we have a real quite a big population. So with regards to the phenotypes, it's often referred to thalassemia major or intermediate, and that generally says that the phenotype is ranging from severe anemia to clinical asymptomatic. Yeah, and I'll just go a little bit more on afterwards about the major and the intermediate. So when we have get a child that's diagnosed with thalassemia, they just follow the pattern of referral, and they will come to us really within the 3 months, even before that actually. And what we do when a child with thalassemia, particularly once we find out the phenotype, if they're beta thalassemia major, it's not the thing that you would automatically transfuse straight away. We would monitor that child for quite a few months. But you'll find that they would start complaining, maybe, well, not complaining, but the parents might say they're not as active as they would be as they're getting a little bit older, or they might play a little bit and just stop quite soon. Also, they've got like a poor appetite, and you'll find if they're feeding, they're breastfeeding, they're not latching on for very long, or they're just feeding little bits if they're doing the milk feed. And also they've got the pale yellowish skin because of the part of the process that the cells are breaking down, and their skin is getting a bit yellowish. And also they got their urine is dark for exactly the same reason. And generally you will find that also they can have enlarged spleen, shortness of breath, and that's to do with the anemia, which is the background of this condition really. And also you'll find that they're failure to thrive from about the age of 6 months. So basically you would monitor the child, and you would look at their hemoglobin, and sort of like if the hemoglobin's around about 80 to 90, we wouldn't start thinking about transfusing. But also if you find that they're having some of these clinical features, you might transfuse a bit sooner. Now, particularly with failure to thrive, the parents will say, well, they were feeding okay up to about 3 months, and then they find out that they're just not feeding very well. There can become a shortness of breath in between their feeding. And that's the time we would say, okay, it was not necessarily dependent on the hemoglobin, it was dependent on the presentation of the child. So generally, if we've got the hemoglobin beta thalassemia, we would generally start transfusing what we'd say in around about 6 months. Now, we talked a little bit about the intermediate as well, and people would assume that intermediate, yes, it does initially present as a milder presentation, but you would also monitor the child, and you might monitor the child for longer, up to the age of 5, 6, and you would see how they're actually doing. And it's not, they might be dropping their hemoglobin a little bit, and so you would see, and sometimes the intermediate, but later on, often go into transfusions as well. And once they go into transfusions, we don't really look at them as intermediate, even though that's what their phenotype might suggest. We look at them as thalassemia major because they've now started a treatment process. Now, if continue with clinical features, you would find also, apart from those other real obvious like shortness of breath and failure to thrive, you get sort of bone marrow expansion. You can get bone deformity, and this is if you go on for a long time with actually out without treating somebody's thalassemia. You get facial bone deformities, and you can get slow growth. Another thing that we do when we look at the thalassemias, and particularly the intermediate when we monitor them, and you have to monitor them 6 monthly to a year, you look at their facial, their face, and sometimes you will see that you'll get sort of like the flattening of the nose bridge. You get a bit of bossing of the skull, and sometimes you get the spraying of the teeth. Now, you would find that sort of like you'll see a sort of a small evidence of it sometimes when they're a bit younger. These are for the thala intermediates. And then you would, and that sometimes could be also a reason why you say you're going to start transfusion, because obviously this is just going to get worse. But with the thalassemia majors, generally we would say for most of them, by age of 1, all of them have started on a program, a transfusion program. And also, as talked about the slow growth that will just happen with the failure to thrive. And if you leave someone with thalassemia major, which you wouldn't really without transfusion, but particularly in thalassemia intermedia. So even though it is a milder presentation, it should be monitored as closely as you would with thalassemia major. So treatment for thalassemia, and I think I did dip in before, so I think you might have had a bit of this, but I will just say it because it sort of goes together with just talking about thalassemia. So regular transfusions, that is for the thalassemia major, and then it could be later on for the thalassemia intermediate, which we refer to as majors once they start transfusion, and iron chelation therapy. Then you can do sometimes a splenectomy, because sometimes the spleen just sort of gobbles up all the cells and holds onto the cells and keeps the hemoglobin quite low. But we try to avoid that now because we feel that the spleen has quite the function of, the infections. We try to avoid taking out the spleen now. And sometimes if you start transfusion early, that process wouldn't necessarily be necessary. And also you've got the bone marrow transplants, which I think there are quite a few children nationally who are having bone marrow transplants. And we haven't had one recently within our trust, but we have one coming up next year. And she's a family where there's 4 children, and 2 of them have got thalassemia. And we knew that she had a match from quite a young age, but the parents was a bit reluctant. But as she's got older, I think the child is expressing her thoughts on it as well, and now they're going for a bone marrow transplant. And also there's gene therapy that is going on as well. But for this sort of short presentation, I'm just going to look more on the transfusions and a bit about iron chelation. So blood transfusions normally are 3 to 4 weekly. And the aim of the blood transfusion is to correct the anemia, and it also allows the child to grow and live normally. So I say 3 to 4 weekly because it does depend on the individual child. And particularly when you're younger, because there's a lot more bone marrow activity, you're growing, you find that the child will need the transfusion around for every 3 weeks. And then as they get older, they go into 4 weeks. But that's not always the case, because there's some children who's into their teenage and still needs it every 3 weeks. So really, it's about tapering it to meet the child. This is what we use as a guideline here at the Royal London Hospital for when we're transfusing the thalassemia patients. As I said before, we've got quite a lot of children with thalassemia that's on transfusions, and the transfusions are done on our day unit by the day unit nurses, and the CNS is just going to support where it's necessary. So it's important for them to have a guideline which they can follow without having to sort of contact the CNS. Do you want to change this? Do you want to change that? And we've got a whole protocol of what we do when we transfuse the thalassemia patients. So if the hemoglobin is below 90, we transfuse 20 mils per kg and then bring back 1 week earlier. And then as you can see, if it's between 91 and 95, we transfuse 20 mils per kg. If it's 96 to 105, we transfuse 15 mils per kg. And 106 to 115, we transfuse 10 mils per kg. And 115, we wouldn't transfuse, and we return in 1 week. Now, when we're transfusing, our aim is to keep the hemoglobin above 90. So that is a level, 90 to actually 100. That's a level where you will get a little bit of suppression of the bone marrow, and it's to keep the anemia to such a degree that you won't impact, like you won't get some of those symptoms that we've referred to with regards to the bossing of the skull, the facial features that you get. You can reduce that or almost stop that if you transfuse efficiently. So it's really important that transfusion is monitored, the hemoglobin is monitored every time that they come. There may be particular reasons, maybe if they're a bit unwell, that the hemoglobin's dropped, but the aim is that you keep the HB above 90. Now, our CNSs here, even though they don't do the transfusion, they will monitor every week all the transfusions just to see that the hemoglobin is okay, to see that they're growing okay, that their weight is okay. What we actually do, we don't actually, we get some cells that may be a bit heavier, overweight, we would say, but we only go up to transfuse. The maximum we would transfuse any child is 3 units. We won't transfuse any more than 3 units. And also, because these children are coming back quite regular, we tried to reduce the amount of time that they stay for their transfusions. So we put and transfuse 5 mils per kg. That's the rate that we go at, but the maximum will be 200. So you can imagine we can get some of us through our transfusions about 2.5 to 3 hours. And that's a bit more manageable for, you know, these families when these patients missing school and coming for the appointments. So collation therapy, I know you've had a little bit about this, but I will just go a bit more into it. And we should start collation therapy after they've received 10 to 12 blood transfusions, or when the ferritin level is consistently above 1,000 micrograms per litre. Now, how do we, we've got a little calculation here that we use at the Royal London Hospital. So we know how much, we add up how much red cells they're having. So we know roughly how much iron we would expect them to have at the end of the year. So it's 1 ml of red blood cell contains about 1.08 milligrams of iron. So a patient receiving an average of 12 to 14 units a year at 250 mils will have an excess of around 3 grams of iron a year. Now, naturally, our body, we have about 4 grams of iron. So if you're talking about excess of 3 grams, you're talking about 7, and then we know that the numbers go up. So we calculate on average, so we know how much iron that they have. And we think it's quite important to start the collation therapy quite soon. Because I think if you start at like 1,500 or 2,000, you're sort of working against yourself very early. So the earlier you start, the better. But when you think about, particularly for the thalassemia major patients, they start like 1, some starts at 6 months. So we're talking about by the age of 18 months, you're wanting them to have collation, which can be quite difficult. So sometimes you find that it actually might go on a little bit higher before we actually start the process of thalassemia. But this, iron collation. But this is actually the ideal over just when it reaches over. And we just say over, but it doesn't actually say how much over. But I would say just a little bit over. So if the iron is not removed from the body, you see it's stored in all these organs, the pituitary gland, the thyroid and parathyroid gland, the heart, the adrenal gland, the liver, testes for women, ovaries for testes for man, ovaries for women, and also the pancreas. They're the ones that we often talk about in thalassemia, is like the liver and the heart, because we know that's where it's stored mostly. But also you can get iron in the pituitary gland, but whereas you can remove iron from the liver and the heart, you can't always remove from the pituitary gland, and you would only notice when they grow older, they're not growing very well or they don't go into puberty. So the idea is to really get on top of this collation from a very, as soon as a very early age, and to engage the family. And I think I listened to something before, we talked about compliance, and we find that compliance generally with the thalassemias in the earlier years is actually quite good, but obviously as they get older to adolescence, that's where sometimes the problems arise, as in all with medication that you're giving. So what is the aim of collation therapy? And I know this bit, I think I heard this bit said before, but it binds with the iron in the body, which is then transported through the body and is excreted in the urine and or stool. So that's the aim of the collation therapy, just to remove all the iron out of the body. So the Desferal, and these, I'm not sure, there's different pumps around, but this is the Cronus Pump that we use. And this is for someone we would use for around 18 months. And we start normally around about 20 milligrams per kg per day. And when we start with the collation therapy, you're thinking we're talking about 18 months, someone who's 18 months old. Some of them are still in nappies and everything like that. So it's very difficult for the parents, first of all, to just get on board with the fact that we're coming every week or every month for transfusion. Then on top of that, we now have to do this collation therapy. Now, this for someone under 18 months, you have to do it manually. And so this is the pump you use. So you have to teach the parents to draw up the powder, to dilute the powder, to give everything. And that can be quite, the parents can become quite overwhelmed with it. But we do have the team, our CNSs, and we all train the parents. They do competencies. And despite the fact that they're really stressed and really worried, they say, we can't do it. In all my years, they've all taken it on board and embraced it really well. And that sometimes when we've even asked say, well, you're age 2 now, you can go into a different therapy. Says, no, we're used to this one. We know about this one. We'll continue on this one. And this Desferal is, as we know, is the first iron chelator that we had, and it's over 30 years old. And we're still using it, and it still works. But the problem, one of the many problems, is that it's just, as people get older, it's just not nice to use injecting yourself. And we would normally start around 2 or 3 times a week, but by the child becomes 5 or 6, it actually even a bit before, we're actually going to about 5 or 6 times a week of the Desferal. And if someone really goes well with it and do it, we can see that it does keep their ferritin quite low. Now, on the right-hand side, you see the picture of a pre-packed filled pump. Now, we'd use those for children who are maybe about 8 or 9, because whereas the Cronus Pump, you can get a solution of 10 mils. These pumps, the minimum is about 37 mils. And you could imagine a 37-year-old, an 18-month-old having a 37 mils in their tummy. That would be too much. So that's what we use the Cronus pumps. And there are some new ones coming out now. We've just had a presentation about it, so we might be using different new versions of these. But this is what we use for all children under around 18 months. Then also vitamin C is really important because it helps to mobilize iron in the bloodstream, creating a more easily chelated free iron supply, and should be taken every day with the Desferal 30 minutes after starting each infusion. And sometimes you give the Desferal and we forget to give the vitamin C, but it really is important and it really does help. And I think the person earlier on talked about some of the side effects. I'm not going to go into the side effects of all these again. So the Xjade is started from 2+ years, and it's from the doses from 7 milligrams per kilogram per day up to 28 milligrams per kilogram per day. Now, I remember when we started, we only had Desferal and Deferoprone, which is on the other side of the slide. And when Xjade was coming in, which I think it was around, we started here about 2016, but I think they were marketing from a lot earlier. And everyone thought that this is going to be revolutionize the world of collation. You're having an oral iron chelator, everybody's going to take it, it's going to be no problem. And it was, we thought this was it. But unfortunately, it wasn't it for many of our patients. And I think many people who's used Xjade, even if it's for sickle patients, couldn't testify of the same thing. And some of our patients on Desferal who came onto Xjade asked to go back to Desferal. Some of them, the creatinine was too high, and so it just wasn't for them. So even though it's an oral iron chelator and we can use it for age 2+ years, we know it's not for many people. And so the Xjade and the Desferal is more focuses on the iron, on the liver ions. And then we've got the Deferoprone, which started in about 1997, I think it was licensed here. And that is aged from age 6+, and this is all to do with the licensing, to do with the age. And it's 25 milligrams per kilogram and must be taken 3 times a day due to the plasma half short life. And this is known to be actually removing the iron from the heart. Now, it's 3 times a day, and the capsules are quite big. And sometimes it's difficult, for some of our young ones, it's the middle one that they can't manage because they're at school. How do they manage that? So there's always challenges when you have medication, any medication 3 times a day, when one of them has to be at school. But we have did you do deferriprone if someone's doesn't have Exjade or Desferal? Because not everything works for everybody, or they can't take it. And we do deferriprone as a single agent, or we do it as a multi-agent with Desferal and or Exjade. So one is looking at the liver ions, and one addresses the cardiac ions. So one thing to know, and this is probably something more that someone would say in the adult side, that in the case of transfused thalassemia, intermediate or major patients, but major wouldn't be so much, but more intermediate patients, the body tries to compensate for the anemia by absorbing more iron from the gut to make more red blood cells. So poorly transfused patients can absorb an extra 0.5 to 2 grams a year of iron from the gut. So you find that if someone with intermediate who haven't chosen to start on transfusion, sometimes the patients decide that they just want to coast along because it's not something for them. You'll find that they also may need to go on iron collation, despite the fact that they haven't had a regular transfusion program. So the annual monitoring, and I think there was something said about this before, so I'm just going to go to this quickly. And the T2 stars, obviously, for the cardiac ions, the audiometry, the toxicity may occur with the Desferal, the ophthalmology, sitting and standing height, which is really important. I remember one mum kept saying to us, because her child is growing, her legs are growing, but her trunk doesn't seem to be growing. And then when we sort of started measuring properly and taking stock, she was actually quite right, by which time there's nothing much more we could do about it. But the Desferal, we thought that maybe the Desferal dosing was too high when she was younger. So really, we said not to exceed 50. I know 40. I know some places I've seen them given 50, but we really tried to aim around the 40 milligram marks. And also we do all the endocrine testing for the sexual development and for the viral screening in blood, which I think you would do for most people who's on a regular blood transfusion program. So these were the annual monitoring that we would do every year. But it's difficult to how do you keep up with this particularly when we have so many patients, to make sure they've done all the testing, to see how much blood they're having, see their ferritin levels. So what we do to do this is our chart that we have. And you see it's got all the annual checks that it's got down there, and you say whether you've done it, put the date, the results, and the comment. And this chart is filled out by mainly the CNSs, and also sometimes the doctors might put in if they've had a ferry scan. So this is what we do on a yearly basis, just to make sure that we keep up abreast with what's going on. And this is just a chart that's sort of like been filled out, and you see we've got the calculation at the bottom of the average HB, so we can know when you're doing the annual reviews if we need to check up on anything, the total meals transfused, so you could actually work out actually how much iron they would probably have from their transfusions, and also the weight, because sometimes this patient is quite good. The weight has gone up, but we've seen that we've looked at some patients and we see from the beginning to the end of the year the weight's exactly the same. So then we have to look at, are we actually transfusing them enough? So we look at everything. And then the ferritin. This one, as you see, the ferritin is quite high there. And then at the top, you'll see that we sort of review the medication. So you can see the Exjade was started at 180. Then we went up to 270, and we're up to 360. And I think there's another one for 2022, so I don't think this is entirely up to date. Also, we look at the creatinine to see, and we monitor that. And the nurses on the ward are quite good, because when they look at the blood results, they might say, oh, look, the creatinine is quite high, or the ALT. So we've got a really good supportive nurses in our day unit that help with this chart as well. So this is what we use really to monitor the patients. And I think I'm going to stop there and just take any questions, because I think my time is about up.
Thank you, Kim. Thank you for that. It's so interesting seeing other centres and how they do like transfusion management, like especially that spreadsheet at the end. It's something that I've definitely started to incorporate into our monthly MDT. So thank you very much for sharing that. I've just got a question here, which is asking how much vitamin C would you recommend?
Yeah, we would give 50 milligrams, and the maximum is 200, but we would normally do 100 for the patients. 100 is sort of like the standard dose that we would do. As they get older, we might add into 200, but we would do a starting of about 100 milligrams.
And they take this every day whilst they're on collation, don't they? Yeah.
Yeah, on the Desferal, because even though we've got the other collation, there's not any proof or it doesn't show that it works in the same way with the other iron collators. So it really is mainly with the Desferal that we do ascorbic acid.
Yep, lovely. Perfect. I've got one here, follow up to the bit, is there a standard nutrition protocol for sickle cell disease? I'll have to come back to that one, Ashel, if that's okay. I've got another question here. Kim, is there ever a concern or worry about increased potassium with irregular blood transfusions? And if so, is furosemide or any other diuretics used? What would be the treatment used?
Okay. It's interesting, that question, because when I actually first started working with the thalassemias, they used to give furosemide with all the patients with the transfusions, but that's not something that we do. And I think that's maybe if they've with the red, because you just get whole red blood cells now. Yeah, no, we don't have any problems with potassium or anything ever, and we don't give furosemide unless with the adult patients you might find that they've got cardiac problems anyway, and that's when you might do it, but not with the children. No.
And I was going to say, if there's any sort of kidney implications or if there's any sort of illness to do with needing a strict fluid balance, then you might consider maybe furosemide. But it tends to be in the older population, I think, not so much children.
Yes, no. In all, they did it historically, but then as they reviewed their practice, they realised it wasn't actually necessary to give the furosemide. And no, we don't do it at all. And we do, when we calculate our bloods, we do mils per kg, as you saw in the chart that I showed. So it's quite particular and quite precise. But if someone has obviously cardiac problems, then we will consider for sure.
Yeah, perfect. Thank you. Oh, and Ashel's question, sorry, was is there a standard vitamin C? Is there a standard nutrition protocol for sickle cell disease? For vitamin C, Ashel, is that what you mean? Sorry.
Yeah. No, I mean standard nutrition protocol.
Oh, sorry, can't hear you very well.
Can you hear me now?
Oh, go for it. Yeah.
No, I'm just asking about the general, maybe standard nutrition protocol as regards to, she was talking about vitamin C and talking about the required, doses, for example. So I wanted to know if there are really an established standard protocol for nutrition generally in managing sickle cell.
No. Okay, so I'm not sure, because you mentioned sickle cell disease, but talk about thalassemia, but that's fine. And I think you would find that with regards to sickle cell or thalassemia, with regards to nutrition, you'd always encourage a good nutrition with these patients. However, if you find that their appetite's falling off or their weight's falling off, you would refer to a nutritionist, a dietitian.
I was going to say that's
that's
exactly what we do.
There's nothing standard that's what you would have. You would just encourage that, but we do refer to a dietitian if we're concerned. And then they will obviously discuss their diet, their eating habits, and work that way.
There's pockets of very small pockets of work that's been done in sickle cell disease and nutrition in particular, which is quite new. So we discussed it briefly on our, we had a talk about it on our Sickle Cell Awareness Day back in July. So I wonder if I'm able to, I don't think there was anything particular in that in terms of an actual guidance, but there is some information and evidence out there in terms of dietary in relation to sickle, so definitely have a look into it. And I think that's it for the time being. Thank you very much, Kim. Thank you for
Lovely, thank you.
taking the time. Yes, no, that's great. So just a few bits and a reminder from me. I don't need to remind you about mics anymore, but the feedback form is certainly in our chat, and I'm hoping Dad can just post it one more time just so it's at the end now, just for completion. And then what I'll do is I'll circulate certificates of attendance probably next week once we've got some feedback forms back. We've got Dad, would you mind sharing the group email as well? So if anyone's got any questions or if they want to follow anything up after today's talk, then to email the generic email address, and then can look to getting back to you with some answers. And as we said, this will be available on our STN YouTube channel. It'll probably be in 2 parts now, where we did a morning and afternoon recording. I'm not sure how we'll edit that, but it'll be available to view after the event. And I think that's it from us. Thank you very much for taking the time to join our education event today. We're doing the same again tomorrow, but for our adult colleagues. So if you guys are signed up to that, we'll see you then. And feel free to contact myself or anyone in the team if you have any specific questions. There we go. So Dow's just posted the KCH-TR email. I'll just tick it there. If you had anything, I'll pin it as well. If you had anything to follow up with. And thank you very much. I'll stay on the call for a couple more minutes. If anyone's got any other questions, etc., then I'm here. If not, then enjoy the rest of your afternoon. Thank you.